So if a surgeon cuts a skin cancer out of your arm and then, a year later a new one pops up right next to the scar, we usually say the cancer came back.
Right, yeah.
Yeah.
That's the standard assumption.
But looking at the stack of clinical dermatology studies and laser therapy protocols we're diving into today, that's almost always wrong. The cancer didn't come back. Your skin just grew a brand new one.
It's a huge shift in perspective.
Yeah.
It completely upends how we think about sun damage. I mean, we are so conditioned to view sun exposure as this simple, immediate cause and effect thing.
Yeah, like you spend a day at the beach, you forget to reapply sunscreen, and you wake up with tight red skin.
Exactly. And then you treat the burn, the skin eventually peels, and we assume the ledger is balanced, right? The story's over.
But the reality hidden in these clinical sources paints a much longer, stealthier picture. That sunburn was just the opening scene.
Oh, for sure.
So welcome to today's deep dive. Our mission today is to look at the delayed consequences of UV exposure. We want to see what happens to your skin 20, 30, or even 40 years down the line. We're specifically exploring actinic keratosis, or AKs, and this fascinating, honestly slightly terrifying concept known as the cancerization field.
And we're also looking at the solutions, because the medical protocols we have today show how modern dermatology is using cutting-edge laser and light therapies to essentially turn back the clock on decades of structural sun damage.
It really changes how you view every single freckle or sunspot.
It does.
So I feel like we need to start with visible evidence, those actinic keratosis.
Right.
The guidelines describe these as rough, scaly patches on the skin. They often just feel like a persistent bit of dry skin that won't go away, usually pink or red, sometimes brown.
Yeah, and they show up exactly where you'd expect them to. The face, the ears, the backs of the hands, and for some people, bald scalps.
Basically all the prime real estate that's been taking a beating from the sun your entire life.
Exactly. The location is the dead giveaway because cumulative lifetime exposure is the driving factor here. And it's important to stress these are absolutely not just patches of dry skin to be moisturized away. Actinic keratoses are precancerous lesions.
Which is a scary word.
It is. The clinical data in our sources shows that an individual with visible AKs has a 6 to 10% relative risk of developing a serious form of skin cancer called squamous cell carcinoma, or SCC.
Now, a 6 to 10% risk might not sound overwhelmingly high at first glance to some people, but the sources frame it differently when you look at it from the other direction.
Right, retrospectively.
Yeah. When a doctor examines a squamous cell carcinoma under a microscope, almost 100% of the time, they find the cellular fingerprints of an actinic keratosis right there on the periphery of the tumor.
Yep. The AK is the precursor. It's the visible warning light flashing on your dashboard telling you that the cellular machinery underneath is breaking down.
But focusing just on that visible spot ignores the most vital concept in all of our sources today. Yes, field cancerization. This concept completely changes the geometry of how we think about skin disease.
It really
Yeah.
does. And the term field cancerization actually dates back to 1953.
Oh, wow, that long ago.
Yeah, it was originally used to describe the spread of oral cancers. But researchers eventually realized it applies perfectly to sun-damaged skin, too. The central idea is that an actinic keratosis does not exist in a vacuum.
Right.
It is surrounded by a contiguous field of skin that, might look completely normal and smooth to the naked eye. But fundamentally, it is mutated at a genetic level.
The papers state that for every single visible AK you can spot on your skin, there can be up to 10 invisible subclinical lesions lurking right nearby in that surrounding field. Up to 10.
It's wild. We have to look at what the UV rays are actually doing over all those decades. They're constantly striking the skin and specifically damaging the DNA inside your cells.
And there's a specific target they hit, right?
Yeah, one of the most critical targets is a tumor suppressor gene called the P53 gene.
Okay, I've seen P53 described in the research as the guardian of the genome. It's essentially the brakes on a car. It stops cells from dividing out of control if their DNA gets damaged.
That's a great way to think about it. So when UVB radiation mutates that P53 gene, those cellular brakes fail. The damaged cell no longer knows how to stop dividing. But the process actually gets even more insidious than that.
How so?
Well, the same barrage of UV radiation also causes the normal, healthy cells in that surrounding area to undergo apoptosis.
Which is programmed cell death, right?
Exactly. So the UV radiation is simultaneously breaking the brakes on the mutated cells and killing off all the healthy neighbor cells.
Wow, so it creates a sort of biological vacuum.
Yes. The healthy cells die off, which clears physical space and removes competition for resources. Meanwhile, the mutated cells, which have lost the ability to trigger their own death because their p53 gene is broken, they survive the UV blast.
And then they just take over?
They do. They take advantage of that empty space, clone themselves, and aggressively expand. You end up with an entire region, a field, of genetically compromised skin composed of these mutant clones.
Just waiting to turn into cancer.
Right. They are waiting for one more genetic hit or environmental trigger to turn into a full-blown carcinoma.
It's kind of like looking at a patch of weeds in a lawn. You see a dandelion, and you just pull it out. But plucking that one visible weed doesn't fix the fact that the entire bed of soil around it is completely saturated with weed seeds.
Yeah, seeds just ready to sprout the moment it rains.
Exactly.
That analogy maps perfectly onto the biology. Spot treating the visible lesion doesn't change the underlying chemistry of the tissue. The soil itself is compromised.
Which brings us back to that idea of cancer recurrence we mentioned at the start.
Right, the cancer coming back.
Yeah. If the whole field is full of these invisible mutant clones, our standard understanding of a tumor coming back is totally flawed.
It is. When a surgeon removes a skin cancer and a new one appears a year later adjacent to the scar, the original cancer didn't necessarily return. The molecular biology strongly suggests it's a brand new primary tumor.
It's just arising from that same damaged field. You remove the weed, but the toxic soil just grew a new one.
Exactly.
So if the entire field of soil is toxic, how are dermatologists actually fighting this? Because it seems like our immediate instinct is just to attack the things we can see.
Well, historically, yes. The traditional approach relies heavily on destructive, lesion-directed methods. Spot treatments, basically. The most common one you'll see is cryotherapy, which is freezing the visible AK with liquid nitrogen.
Or they might physically scrape it off, right?
Yeah, with a curette, or use minor surgery to remove it.
And looking at the clinical data, it does show that cryotherapy is highly effective for what it's designed to do. Like if a doctor freezes the spot for over 20 seconds, the response rate is up to 83%.
Which is great for that one spot.
Right. The targeted tissue dies, falls off, the lesion is gone. But based on this field cancerization concept, you've basically just played whack-a-mole. You've ignored the invisible field of up to 10 other subclinical lesions just waiting their turn.
Which is exactly why the field of dermatology had to develop what we call field treatments.
Yeah.
To treat the whole area, to fix the soil, doctors prescribe specific topical creams designed to seek out and destroy those invisible mutant clones.
And the heavy hitters detailed in the guidelines are 5-fluorouracil, commonly known as 5-FU imiquimod, and diclofenac.
Right, those are the big three.
But looking at the clinical protocols for these creams, the reality of using them sounds like an absolute nightmare.
It's definitely not easy.
I mean, 5-fluorouracil, for example, is literally a topical chemotherapy. It inhibits DNA synthesis, so it starves the fast-dividing mutated cells. And imiquimod takes a different approach. Yeah. It's an immune response modifier, so it tricks your body's immune system into flooding the area with white blood cells.
The mechanism of action for these topicals is incredibly robust. I mean, they do effectively clear the field. However, the massive drawback highlighted across all the patient outcome sources is that these treatments require an incredible amount of physical and psychological endurance from the patient.
Endurance is the right word.
They are absolute marathons.
A marathon is almost an understatement. The guidelines state that 5-FU takes 2 to 4 weeks of daily application. Diclofenac takes 2 to 3 full months.
And imiquimod can take up to 16 weeks of continuous use.
16 weeks. And you're not just rubbing in a soothing night cream. We need to talk about what this actually looks like because the side effects are severe.
Well, the goal of these creams is to induce a localized immune crisis. So by definition, they cause a severe, robust inflammatory response.
The sources describe patients experiencing intense redness, crusting, severe burning, swelling, ulceration even.
Yeah, their skin is literally weeping and scabbing over. The skin looks and feels terrible for weeks before it even begins to heal. You are systematically inducing chemical damage to peel away that mutated field.
Wait, so the gold standard treatment requires a patient to essentially walk around with a painful, peeling, chemically burned face for up to 4 months.
For some regimens, yes.
It's no wonder patient compliance is listed as a massive hurdle. Asking someone to endure that level of visible discomfort while trying to go to work and live their life, people must just throw in the towel halfway through.
Oh, they do. Patient dropout rates for these traditional creams are a significant issue in clinical dermatology. The aesthetic and physical toll is simply too high for many to tolerate.
Understandably.
Yeah. Now, medical science recognizes this, and the sources do point out that newer, shorter duration topical treatments are emerging. Like, there's a drug called tirbanibulin that only requires a 5-day application regimen.
Which is much better.
Much better. But overall, the grueling side effects and the sheer duration of these chemical therapies have pushed researchers to find faster, more elegant solutions.
Patients are desperate for a sprint instead of a marathon.
Exactly.
And this is where the treatment protocols shift from chemical creams to high-tech hardware. We are talking about photodynamic therapy and fractional lasers. Let's break down photodynamic therapy, or PDT, first. How exactly are we using light to kill cancer cells?
So PDT is an ingenious two-step process. First, the doctor applies a light-sensitizing drug, typically something called ALA or NL as a cream over the entire sun-damaged field. But unlike the chemotherapy creams, you don't use this at home for weeks.
You just do it in the office.
Right. You sit in the clinic and let it incubate on the skin for 3 to 6 hours.
And during those hours, the mutated cells are essentially hoarding the drug, right?
Yes, because the mutated, rapidly dividing cells in the field have a hyperactive metabolism compared to normal cells. They preferentially absorb the light-sensitizing drug, gobbling it up, while the surrounding healthy cells largely ignore it.
That's amazing. And then comes step 2.
Step 2. The doctor exposes the entire treated area to a very specific wavelength of light, usually an intense red light, though some newer protocols even use natural daylight.
And what does the light do?
When that specific light penetrates the skin and hits the drug that is now stockpiled inside the mutated cells, a violent chemical reaction occurs. It generates reactive oxygen species.
Which induces cytotoxicity, meaning it's highly toxic to those specific cells. It basically blows them up from the inside out.
Exactly. It selectively destroys the dysplastic keratinocytes, which is the medical term for those mutated precancerous skin cells.
Oh, yeah.
And because the healthy cells didn't absorb much of the drug, the surrounding tissue is left largely unharmed.
It's highly targeted.
Highly targeted, localized destruction.
That is a massive leap forward from braining your whole face with topical chemo. But the clinical sources introduce another piece of heavy machinery that takes this to a whole new level: the fractional CO2 laser.
This is where it gets really exciting.
Now, older, fully ablative lasers used to basically vaporize the entire top layer of your skin, leaving patients raw for weeks. But the fractional part of this new laser technology does something fundamentally different, right?
Right. Traditional ablative lasers carried significant downtime and a real risk of scarring because they removed the entire epidermis at once. Fractional CO2 lasers operate on a completely different principle. They fire a microscopic grid of energy columns into the skin.
Like a grid of tiny dots.
Exactly. They vaporize pinpoint channels of tissue, literally drilling microscopic holes. But they intentionally leave surrounding areas of healthy skin completely untouched.
Okay, so going back to our lawn analogy, it sounds exactly like aerating a compacted lawn.
Yes, perfect analogy.
You punch thousands of tiny, deep holes into the bad soil, which allows water and air in so the lawn can rebuild. And because you leave enough healthy grass intact around every single hole, the lawn recovers in days, not months.
It's very similar to aerating, but with a crucial biological twist. When you aerate a lawn, you're mostly just making physical room. With a fractional laser, those tiny columns of untreated healthy tissue you leave behind serve a specific medical purpose.
What's that?
They act as a localized reservoir of stem cells.
Oh, wow. So they aggressively jumpstart the healing process.
Exactly. Because the stem cells are right there, immediately adjacent to the microscopic wounds, they migrate into the channels rapidly. This allows for new collagen formation, intense skin remodeling, and a complete resetting of the tissue, and all with just a fraction of the downtime seen with older lasers.
So PDT uses light to selectively assassinate the mutated cells, and fractional CO2 lasers aerate the skin to trigger rapid stem cell rebuilding.
Right.
But the absolute holy grail in the research we're reviewing is what happens when clinicians combine them, the ultimate combo.
Yeah, this combination therapy represents some of the most compelling data in all our sources today. Because the core problem with any topical drug, including the one used in PDT, is just getting it into the skin.
The barrier.
Right. The main barrier is the stratum corneum, which is the outermost layer of dead, hardened skin cells.
It's basically nature's waterproofing. Keeps our insides in and the outside world out.
Precisely. By using the fractional CO2 laser first, you deliberately compromise that barrier. You drill those microscopic channels straight through the stratum corneum.
So when you apply the PDT cream immediately after the laser treatment, It doesn't just sit on the surface struggling to absorb, it pours down those microscopic channels.
It penetrates massively deeper into the tissue. The laser-assisted drug delivery increases the penetration of the light-sensitizing drug by several orders of magnitude.
Which means it reaches mutated cells that would have otherwise been too deep to treat.
Yes. Furthermore, the thermal effect, like the residual heat left in the skin by the laser, actually boosts the subsequent photodynamic chemical reaction. It makes the cell destruction even more efficient.
The results of this combination are phenomenal. Let's look at the numbers from the massive 5-year follow-up study detailed in the guidelines. This study looked at combining CO2 lasers and PDT specifically for treating basal cell carcinomas.
Right, which are actual established skin cancers, not just the precancerous AKs.
Exactly. And this combo therapy had an astonishing 93.6% success rate in keeping the treated areas completely free of cancer for 5 full years.
A 93.6% clearance rate over 5 years is incredibly competitive with traditional surgical excision. But it achieves that without ever picking up a scalpel.
And the downstream benefits of that are huge. I mean, if a surgeon cuts a tumor out of someone's nose or cheek, they are left with a permanent scar. Sometimes they require a complex skin graft to close the wound.
Right, the cosmetic toll is significant.
But with this laser PDT combo, the cosmetic outcome is vastly superior, resulting in virtually zero scarring. And for the healthcare policy analysts out there, the economic impact is just as impressive.
Well, the cost savings are incredible.
The data shows this protocol saves healthcare systems, like the UK's National Health Service, about 43% in direct costs compared to surgical excision.
The projections indicate that shifting to this treatment could save the NHS upwards of £70 million by 2025.
Wow.
It really is a rare convergence in modern medicine. I mean, it's a less invasive, physically more tolerable experience for the patient. It yields superior cosmetic results, and it is significantly cheaper for the hospital system to administer.
You're reducing the tumor bulk with the laser, mathematically enhancing the drug delivery, and then selectively detonating the remaining cancer cells with light. It's elegant.
It really is.
But, it also begs an incredibly tempting question.
I think I know where you're going with this.
If CO2 lasers and PDT are so exceptionally effective at clearing out sun damage, resetting the cellular field, and destroying early cancers, can we use this technology to prevent skin cancer entirely?
The force field theory.
Right. Can someone just go in for a preventative laser session and make their skin immune to their past bad habits?
The prevention debate is where the medical data forces us to take a step back and, separate exciting theories from clinical reality. The research here is quite nuanced.
Yeah, the sources definitely pump the brakes on the idea of a laser force field.
Though there are some very provocative preclinical data. For example, one study focused on hairless mice that were systematically exposed to UV radiation.
Poor mice.
Right. But when researchers treated those mice with fractional CO2 lasers concurrently with their UV exposure, the mice showed significantly reduced tumor occurrence rates compared to the control group that only received the UV rays.
So the laser clearly improved dermal remodeling and delayed the onset of the cancer.
Exactly.
Which sounds incredibly promising. You just laser away the bad mutated cells while they're still microscopic before they ever have the chance to cluster into a tumor.
It does sound great. But we always have to remember that a highly controlled study on mice doesn't automatically translate to complex human biology.
The clinical reality for human beings is much more stubborn. The sources highlight a critical 1999 study that serves as a major reality check here.
A very sobering study.
Researchers took 35 patients who had extreme long-term sun damage, individuals with severe, widespread field cancerization. They treated their facial skin with full CO2 laser resurfacing to strip away the damage.
And yet
within months of the treatment, 14.3% of those patients still developed brand new actinic keratosis and basal cell cancers right in the middle of the newly lasered regenerated skin.
Right. A 14.3% failure rate within months is substantial when you're aiming for cancer prophylaxis or prevention.
So why did the new skin still grow tumors?
It really comes down to depth. A human with decades of accumulated sun damage doesn't just have mutations sitting neatly on the surface. They have complex, multi-layered genetic mutations across a vast three-dimensional field.
So the damage goes deep.
It's very deep. The laser PDT combination is powerful, but it has physical limits. The sources point out that if a tumor or a cluster of mutated stem cells extends deeper than 2 millimeters into the skin, the failure rate spikes significantly.
2 millimeters doesn't sound like much, but for skin, that's deep.
It is.
Because the laser can't safely drill that deep without causing severe scarring, right? And the red light from the PDT can't penetrate deep enough to activate the drug in those deep roots.
Exactly. The laser strips away the top layers of photo-damaged skin and forces the tissue to rebuild using deeper stem cells, perhaps residing down in the hair follicles or sweat glands.
But if those deeper stem cells have also been hit by UV radiation,
Right. If they carry that broken P53 gene mutation, the new skin they build will still be compromised. The laser cannot guarantee that the deep soil is clean.
so it is definitely not a magic shield. You cannot just visit a medical spa, get a fractional laser treatment, throw away your sunscreen, and confidently bake on the beach for the rest of the summer.
No, absolutely not. The underlying biology simply doesn't support that. Lasers and light therapies are phenomenal tools for pressing the reset button on existing visible damage and superficial field cancerization.
They clear out the junk.
They clear out the accumulated cellular junk and mutated clones better than almost any alternative. But they do not alter your baseline genetic susceptibility. They do not edit your DNA to make you immune to future UV damage.
Which means the ultimate preventative measure is shockingly low tech.
It is the advice dermatologists have been giving for decades. Sunscreen, specifically broad-spectrum SPF 30 or higher, along with protective clothing, remains the only proven way to prevent the development of these mutated fields in the first place.
You can use advanced lasers to clear the weeds and aerate the soil, but if you continuously let toxic UV radiation rain down on the garden, the brakes will fail again.
And the weeds will always come back.
So what does this all mean for you listening right now? Let's trace the arc of what we've unpacked today. We started by revealing the invisible, decades-delayed threat of field cancerization. We learned that for every visible sunspot or rough patch, there is a hidden, contiguous network of genetically mutated cells driven by UV damage that physically broke the P53 tumor suppressor gene.
The guardian of the genome.
Exactly. We looked at the exhausting, literal marathon of topical chemotherapy creams that leave patients peeling and in pain for months just to clear that invisible field.
A very high price to pay.
And finally, we explored how the pinpoint precision of fractional CO2 lasers combined with photodynamic therapy is revolutionizing treatment. Punching microscopic channels to let light-activated medicine wipe out the bad cells and stimulate fresh stem cells without the need for a scalpel.
It is a powerful reminder that skin health operates on a profoundly deep cellular level. I mean, whether you were currently dealing with a few rough patches left over from your sunny 20s, or you're simply trying to understand the complex biology of how our bodies age, knowing about the cancerization field changes your entire perspective.
Really does.
It is never just about the isolated spots you can see. It is about respecting and protecting the health of the entire canvas.
And that leaves us with a final provocative thought to mull over. If our skin's entire history of sunbathing and sunburns is quite literally written into our DNA through mutations in the P53 gene, and we are right now finding ways to selectively erase that bad code using microscopic laser grids and light-activated drugs, where does this technology go next?
A fascinating question.
Could we eventually map and dynamically edit our skin's molecular age on a cellular level before a single visible sunspot ever has the chance to appear? Could we one day rewrite the fundamental code of the soil itself, ensuring that the weeds never even have a chance to take root?